the whole
No, Wadud bolo.
Sir, আমরা এখন লাইভে যাইনি। Can you wait for a few minutes? আমি লাইভে গেলাম।
আমরা লাইভে যাচ্ছি স্যার, আমরা বলতেছি স্যার।
আজকে স্যারটা আপনি বলবেন স্যার, আমি তো আজকে করছি না।
আজকে টকটা হলো সুধীরের, তাই না? আমি
টিচার হিসেবে স্যার আপনি।
Dear moderator, you can start your talk.
সুধীরের Tushar, you can start now.
Okay. Assalamu alaikum and good evening, dear physicians. Today is the 50th day that we are going to present case-based ECG and discussions in our page ECG study group. It's a milestone achievement for us, and I'd like to pay my deepest respect to all the course directors, international advisors, moderators, and the participants for their cumulative effort to make this happen. So today we have a guest presenter as Dr. Sudhir, PhD resident from BSMMU, and he will be guided by Professor Abdul Chowdhury sir. And before going to start the session, I'd like to request Professor Rafique Ahmed sir and Atahar Ali sir to say some words regarding the session and ECG study group and the 50th lecture session. I'd like to first request Professor Atahar Ali sir to say some words.
Thank you, Dr. Tushar, and good evening, everybody. And actually, this is the talk number 50, and this is the glorious journey of the ECG study group. Our main objective of this program is to actually teach our students, that is fellows, residents, and this is our main objective. And during this period, actually, we have learned that is a good number of participants and students actually regularly join in our program, and Sudhir is one of the example of that regular participants, sir. And because of this, we have selected, actually, Sudhir is one of the example that will start this program, but sometimes off and on, we will introduce some of our students, among our students, residents, to present in this forum as a speaker. That is what is the actually our achievement. I think during the whole period, Professor Abdul Wadud Chowdhury, Dr. Rafique Ahmed sir, Professor Hafiz Chowdhury, and some of our panelists, particularly I can see Professor M.G. Azom, Professor Mohsin Hossain, Dr. Naharuma, many of the panelists actually participated in this program. And I think I have got many of the phones from our participants that they are actually enjoyed this program, and they learn. And particularly from myself, I have been learning a lot. I don't know what is the end of this learning. I don't know. This is the big from all of our presenters. Even I hope I will also learn even today from Dr. Sudhir. So Sudhir is our example, sir. Sudhir is a resident, that is a phase B resident, BSMMU cardiology resident, and a regular participant of this program. And in this reason, actually we have introduced Sudhir. And I am requesting Professor Abdul Wadud Chowdhury to introduce Dr. Sudhir as a student.
Good evening, everybody, and assalamu alaikum. Actually, as Professor Atahar Ali Bhai was saying, it is really a moment of pride for us. Back in 2014, we wanted to start something. Back in 2017, me and Atahar Bhai, we started the ECG study group. We started taking different lectures on different topics in different parts of the country. And in the COVID era, there's a new dimension. We cannot go anywhere, but the world will come to us through the digital media. So the world is in Western now in our hands, if we want to use it properly. And the end result is we have been continuing this form of lecture where both national and international faculties are participating, contributing, and having a very interactive session. This is the 50th program we are having. Atahar Bhai and myself are really grateful to all the faculties and particularly to our mentor, Professor Rafique Ahmed and Professor Chowdhury H, Ahsan. And also to our colleagues and peers in this country, and to the audience, our students, their encouragement, their involvement, their enthusiasm. That's what led to us continue this program. We hope, and the program will be beneficial. As Atahar Bhai was saying, all of us are learning, myself included. Sudhir is our student, have been there from the very beginning. Very enthusiastic involvement. And that's why we selected that he should be the representative of our student in today's program. And each month we'll have a session where a student and a teacher both will participate together, bring out case-based scenarios, and the faculties will be contributing in the discussion. Let us not delay further. I wanted some comments from our mentor, Dr. Rafique Ahmed, and then we'll be continuing into Sudhir's program for which we are waiting. Sir.
Thank you all. This is our 50th lecture. I mean, this is a big accomplishment for any group to conduct, but mainly thank you all for participating in it. I mean, we would not have got the encouragement if you did not participate, and the participant number is large, and our job is to disseminate knowledge. At the same time, we keep learning, and that is our motto. It is not only for the students, it's for everybody, from junior faculty, senior faculty, for me, and for all of you that are participating. And without delay, we'd like to start today's session. Thank you again.
Sudhir, you can start sharing your screen.
Thank you, sir.
After Sudhir's talk, there will be talk from Professor Rafique Ahmed, sir. Dr. Sudhir, you try to finish in half an hour. Professor Rafique Ahmed will follow you.
So, Assalamu alaikum and a very good evening. I'm Dr. Sudhir, a Pacemaker Cardiologist resident from Bangabandhu Sheikh Mujib Medical University. And today, firstly, I would like to say that I'm really very happy. It's a matter of honor and pleasure for me to be in a platform like ECG study group. And I'm really grateful to two legendary professors like Professor Abdul Wadud Chowdhury and Professor Atahar Ali sir for giving me an opportunity to say something in this forum. And they are really, I really respect them as a human being, honestly speaking, and not as a doctor, because they are great humans. So today, I would also like to greet the teacher of teachers, Rafique Ahmed sir, and in other words, I can call him the great grand teacher of mine. And today's compilation of my ECGs will just be a reflection of what I have got to learn from Rafique Ahmed sirs in this long journey. So without wasting any much time, I would like to go on directly to my session. So this is my first ECG. So let's start with the easy one. This is my first ECG. So what is the diagnosis here?
I'd like to have some comments or students, you can raise your hand and try to answer it. রিফু দেখো কেউ হাত তুললে তাকে ঢুকতে দাও।
জি স্যার। or even attendees can answer in the question answer or chat box as well if they want to.
ঠিক আছে।
Sudhir,
Yes, sir.
I think you actually describe, and I will actually hear the comment from Rafique Ahmed sir after your comment.
Okay, sir. So if we look at the ECG, it has two rhythm strips. And as we glance across, we see that the QRS is fairly regular with a rate just above 60 beats per minute. So let's count. It's just above 60 beats. It's likely to be around 65 beats per minute. Okay. Now, when you first look at the QRS complexes, it looks like it's wider. So it's at the upper range of the normal. So it's likely to be 120 milliseconds or so. So I think that I'm looking the ECG, there is a temptation to call it an accelerated, because you know that when impulse arises from the sun, we call it junctional rhythm. And rate will be about 60 beats per minute. And since the rate is about 60, we are calling it junctional. But we are calling it junctional. The reason is, if you look very carefully, there are no P waves preceding QRS complex. So you won't find any P waves anywhere in any of the leads preceding QRS complexes. And that's why, and since the rhythm is fairly regular, we are calling it junctional rhythm and not atrial fibrillation. Because we know that even in atrial fibrillation, the P wave will be absent. But what will be the rhythm? The rhythm will be irregularly irregular. So there is a temptation to call it accelerated junctional rhythm.
Dr. Sudhir,
Okay.
before Rafique sir comment, I want to make a comment.
Okay, sir.
Sir, from the V1, the morphology of T wave is distorted. The terminal part, that is the second part of the T wave is terminated. I think there is a superimposed P on the T wave, and it is clearly seen. I say it is clearly seen in the V1, also in lead 2. Do you think that there may be a P wave in the T wave? That is the second part of the T wave in lead V1.
Best seen in V3. Look at V3.
Yes, sir.
V3
is
clearly seen.
V3.
Do you agree, Sudhir?
Yes, I do agree with you, sir. There's nothing not to agree with you. You are absolutely right. So if you look it very carefully, you see we don't find any P waves here. But now come to the T waves. So if you look, if you come here, you see if you come here, if you come here, you see this is the P wave. But what is this sharp deflection? Just following the T wave. So here is one, and you see there is also a small tiny deflection immediately after the T wave. What is this? And here, the sharp deflection has brightly superimposed on the top of the T wave. And you see, that's why this T wave is a bit peaked in comparison to the previous T waves. So this is nothing, but it's likely to be P waves. Okay. So we are getting P waves, but these P waves are very complex. So it means that we have P over here and the QRS is here. So the QRS is all right. There is QRS complexes and P is here. So if we calculate, the PR interval is very, very long, and it's almost 3 large boxes. It's about 600 milliseconds. So if you think that this is an accelerated junctional rhythm, so you are wrong, because it's nothing but it's just first degree heart block. and a first degree AV block. And we have studied that the first degree AV block are usually asymptomatic, and we don't have to even bother for the first degree heart block. Okay, but these are first degree heart block. It has been mentioned in chat. If the P are very long and if it is superimposed on the top of the T wave, these patients are usually symptomatic. As like that, the high degree blocks, like second degree or even the complete heart blocks. So we have a first degree heart block. So what else is there?
Sudhir, one more question before Rafique sir. There is a combination of the LVB and the first degree heart block. Do we want to call it bifascicular, trifascicular block like this, or you want to call it separately, that is LVB with the first degree heart block?
Sudhir, we have lost the sharing. Can we start sharing the screen again?
Sir, our network chole gechilo, sir, sorry. Okay, sir.
Sir, Rafique sir, I think the
No, I think well discussed. I mean, the question is, the heart rate is 68 beats per minute. It's a wide QRS with 120 milliseconds. So it's left bundle morphology. It's not ventricular beat because if you look at V3, then initial R is very narrow. So it's either junctional or something supraventricular driving it. And of course, clearly you can see in lead V3 specifically, you can see that notching, and then the next one is a little bit peaked. And that subtle difference tells you that this is something superimposed. You can also see that P wave in lead 2. So it's sinus rhythm with first degree AV block, left bundle bunch block. The question is, what is the presentation of this patient? I mean, if this patient is asymptomatic, as Sudhir was mentioning, sometimes they can develop what we call like pacemaker syndrome because the P is on the T wave. But most of the time, we cannot justify pacemaker implantation unless they have really syncope, pre-syncope, or we can clearly prove that there is this is symptomatic. Sudhir, you have lost your net again.
I again lost my connection. Sorry, sir.
The point is the patient has axis deviation, wide complex, very prolonged first degree heart block, PR interval.
Yes.
Is this patient very likely to proceed into complete heart block?
So the question is the patient going to more likely? It's interesting that if you study his bundle system, with syncope patient, we find prolonged HB more so in shorter AV delay than longer AV delay, because most of these AV blocks are in the AV node. It's kind of, you expect that you will find HV prolonged, that in for his conduction delay with a longer AV delay, which is most of the time not true. It's supra his conduction delay, which is the first degree AV block. So, I mean, it will all depend on the patient's symptom. So if the patient is symptomatic, then we'll do further workup on this. If the patient is not symptomatic, we will not pursue any further. But eventually, these kind of patients are going to end up needing pacemaker. Other thing that I will probably do, I'll make this patient walk. If I find that with walking on a treadmill, rate goes up, and at a rate of 100, 110, a PR gets shorter, that's a good news. But sometimes they develop 2-to-1 heart block with low level of activity. Then it clearly becomes, and another symptom these patients present with exertional shortness of breath, not because of complete heart block, but because of intermittent 2-to-1 heart block. And that is not an uncommon presentation in this kind of patient. So you have to keep an eye on that for this.
Can I ask a question, sir? Wadud?
Yes, go ahead.
Sir, can I ask a question, sir?
Go ahead, Atahar. Atahar. Yes.
Sir, if this is the post-MI situation, if this is a case of the post-MI situation, do we want wait for the symptom that is a symptom of the bradycardia, or we can go straight for the pacemaker, sir, post MI?
Because there seems to be a probable anteroseptal MI. If the lead is properly placed, then V1, V2 shows clear-cut Q.
Yeah, that thing can be also lead position. Sometimes, with left bundle, we don't. But to come to Athar's question, if this happened because of anteroseptal MI, the patient will go into heart block because you have damaged the infrahis conduction system. So rather than first degree AV block, you will get complete heart block. It can happen more so from inferior MI, because inferior MI can cause suprahis conduction problem that you will get first degree AV block. So that answers your question probably.
Thank you, sir.
Is there any?
Next is Sudhir.
Is there any left bundle branch block here?
Yes, it is left bundle branch block. Because you look at lead 1.
Lead 1 AVL.
Why? And then lead
but why
V6.
will sir AVL
Go ahead.
have this Q wave? It is left bundle branch block, sir.
I think this is left bundle branch. If you look at lead V1, V2, and also lead V6 is kind of funny because there is terminal S, but that terminal S is not reflected in lead 1. If you do,
because of this.
If you do a more lateral lead of this patient, if you do V7, V8, you will find typical left bundle pattern.
Sir, could it be non-specific interventricular conduction delay?
I mean, you can use that term, but from V1, is this a book ECG or your ECG?
Sir, it's been collected ECG.
From a patient or from a book?
From a colleague of mine.
Yes.
From a patient. From a patient.
Is it from a patient or he collected from a book? Because this ECG tracing is from a book. Why?
No marking of the speed.
No, no, not only that. The way it is edited, nobody in Bangladesh can do this kind of editing as a physician. So I think what we should do is that we should present ECGs that are our patient's ECGs, real life. Then we can discuss cases. At this point, the discussion is going to be a theoretical discussion. And that's what we have been learning for years, that we have been learning from the books. I think we need to learn from our cases. That becomes more interesting because with this, we cannot discuss anything about this patient. We don't know the patient. We don't know the age of the patient. We don't know the background of this patient. So this is a good ECG discussion though. So let's continue.
Should we go for the next ECG?
Okay, sir.
Do they describe this ECG? And
Okay, so if we look at the rhythm strip, it's very regular. Okay, and every QRS complex is preceded by a P wave. And if we look at the rate, it's below 60. So we can simply say that the patient is having sinus bradycardia.
Sudhir, can I interrupt you,
Yes,
Sudhir?
Yes, sir.
Actually, may I please try to actually what we Professor Wadud Chowdhury, B, Rafique sir always, what is actually our teaching to our student is that try to describe it systematically. That is the rate, rhythm,
Okay.
interval like this. I think that will be a
Okay,
good practice.
Okay, so rhythm is regular, and the rate is about 50 beats per minute. So it's and each of the QRS complex is preceded by a P wave. So we can call it sinus bradycardia. If you look at the axis seems to be normal. But if we come to the precordial leads, we see that the R wave is poorly progressing, and there is a deep S wave in V1, V2, V3, and there is slight ST segment elevation in V1 to V3. So V1 to V3. So my question is it simply a sinus bradycardia? Because the ECG cannot be that simple. So if we come back to the ECG, what we see is, now if we come back to the PR interval, if we look at this PR interval, it's about 180 millisecond. Okay, and if we come to the last, you see that the PR is getting over the QRS complex. So the PR here and the PR here does not match. So the PR here is longer, and as it progresses, the PR is getting shorter. So this PR is likely to be 130 or 140 millisecond. So there is the difference of 40 millisecond. And in between, we have 6 beats. So altogether, each beat, the regular, if we call it regular, it's not actually regular, it's irregular. But it's so small, the irregularity is so small that our eyes cannot perceive it. So there is some degree of irregularities persisting in between each beats. So what is the reason that the PR is getting shorter and shorter? We only know that the PR interval gets longer and longer in type 1 of second degree AV block. But what is the reason that the PR interval is getting shorter and shorter? Sir, bolbo sir.
You have comments, na? But before that, anyone, our panelist or participant?
Ajit bhai, you have to unmute.
Yeah, this is a very distinctive EKG, definitely. We see the main thing that in this ECG, we see that the PR interval is shorter. And not only that, the question about the initial deflection of the QRS when it's getting shorter, we see some delta wave pattern, okay? The question right now, if there is dynamic like AV conduction going on directly, not through the node or through the bypass tract or something that's progressing a little bit, that can cause the fusion beat, that can cause the PR interval getting shorter. But I don't see, at the very end, I see certain delta wave, probably, if you can look at V4, that probably better seen, and slight slurring of the initial complex of the QRS. So there could be some bypass tract there, and that's quite possible. I don't know if we can comment better, probably. Sure.
Dr. Maghfur Rahman raised hand. Review, can you connect Maghfur Rahman?
Yes, sir. Dr. Maghfur Rahman has been permitted to talk. You can talk now.
Maghfur Rahman connected?
Yes, sir. He has not unmuted himself.
Maghfur, can you unmute yourself?
Or anyone volunteer
Sir.
participants connected?
So there might be a network glitch, and Khurshid Alam has raised his hand.
Connect him.
Khurshid, please make a comment.
So their mics are turned off.
Khurshid, please make a comment. Unmute yourself, please.
So I think there is a connection problem.
Yes, sir, because their mics are still muted, sir. Microphones.
Rafique sir, would you please make a comment on it?
No, I think Sudhir, what is your
Diagnosis.
So this QRS does not seem to be the one conducted from the coming from the atria. Otherwise, difference between the P wave and the QRS complex. This QRS is a junctional escape. Okay, and this P is coming from above, so from the atria. So these are the escape junctional rhythms. I mean, this P. So this P and this Q. So if we compare with this, there is a wide variation between the last PR and the first PR. So I think these QRS complexes are the junctional QRS coming from the junction, and it's overlapping over the P waves.
You are trying to say this is isothermic dissociation, right?
Yes, sir. Yes, it's a VA conduction.
Sir.
Yeah, I think you Sudhir, you did it. Your explanation is perfect, except I will not use the term junctional escape because the junctional rate is a little faster. Basically, what's happening that the sinus and the junction, they are very close to each other.
Yes.
And the junction is becoming little faster. And the reason it is not W, Ajit mentioned WP, surely there is a little slurring in V4 and V6. However, if you look at the rhythm strip below, you can see that the sharp after the P wave. So there is no P wave. Usually, if it is pre-excitation, the QRS will start from the P wave. So it is basically, it's a very interesting ECG that you have a junctional rhythm which is very close to the sinus ray, and that's what is happening. If it were Mannheim fiber, as one was mentioning, you will see persistent short PR interval, and normally it will be a bundle branch type ECG because Mannheim goes from, it's atriovascular tract. So there is no such thing. So the other thing is that please watch out the high voltage ECG. Some patient may have left ventricular hypertrophy. So that's great ECG. Thank you.
From practical point of view,
yes,
when one sees this type of ECG in a pre-op checkup,
yes,
should they be concerned about it?
Yes, I was about to tell that. What is the importance? What is the importance of identifying this ECG?
Exactly, that's my point.
It is what we call theoretical mathematics. What is the importance of theoretical mathematics? That means our eyes are good enough to identify it. This thing has no clinical relevance at all. I mean, I will clear this patient for surgery unless there is something else is going on with this patient. It has no clinical relevance in management of this patient. But it's important ECG to identify, to be able to look at it and say, this is what it is. Thank you. Sudhir, next.
Sudhir, sir, I am requesting Sudhir to just present one more ECG, Sudhir.
Okay, sir. Okay. So this is the next ECG, sir. An 18-year-old girl with complaints of palpitation.
So you please describe the ECG, Sudhir.
So should I describe sequentially or should I describe only the findings?
Yes, systematically, please describe.
you see the rhythm here to be very regular, okay, in this portion. And only 1, 2, 3, 4, 5, 6. The rate is nearly 50 beats per minute. But the interesting, there is no P wave in front of the QRS complexes. So QRS is devoid of P wave, and so is this, and this, and this, and this. But if you look back here, we have a definite P wave in front of the QRS complex, okay? And there are other QRS having P waves. So here we have a P wave. Sliding upward of the QRS complex. So there is a delta wave. So delta wave is there in all of the complexes. So what is the reason that this is having a delta wave, but there are no P waves in some of the delta waves, but there are P waves in the rest of the delta waves?
What is your diagnosis, Sudhir? Welcome, Chowdhury Ahsan.
And if we look here, we have, and if we look here, we have a high voltage ECG, high voltage in the precordial leads, and there is a Dagger-Sept T wave inversion in the precordial leads. So in V3, V4, V5, V6. This is a patient ECG.
Hello. Hello.
Sudhir,
Hello, Sudhir,
Yes,
can
sir.
you hear us? Hafiz Bhai, welcome. We are seeing you.
How are you?
Allah Rahmate, এখন পর্যন্ত। Sudhir,
Sudhir,
have you been able to get connected?
Sudhir, are you connected? I think Chowdhury Hafiz will happy to see this type of the T wave. We can have a comment from the Chowdhury Ahsan as well, because Sudhir is not connected.
Hafiz Bhai will not be very happy because whenever you have a delta wave visiting the QRS complex, all the T wave importance gets invalidated. So
Yes, you are right. I have a rule: the uglier the T wave, the less likely ischemia. The uglier it is, then worry less. There is something else going on. And of course, in this 18-year-old, this is not ischemia, by the way.
Sudhir, are you connected with us?
Sudhir, are you connected? What is your final diagnosis, Sudhir?
Sir, he's not here. I mean, he is here, but everything is stopped.
It's raining outside, so there's
Yes, sir.
our network is so poor.
Anybody to talk about differential on this?
Abdullah
Can I say
Jamil.
something?
Yes, Abdullah Jamil.
Okay. To me, it seems the first complex is normal with P wave with a delta wave, and second one is an atrial ectopic that is conducted through the conductive system with a more discernible P wave than the previous one. And later, the rhythm seems to be junctional bradycardia, and with a probably there is a retrograde P wave superimposed on the ST segment near the T waves. And this young lady probably has hypertrophic cardiomyopathy, which is often associated with accessory pathways. That much I can understand from this issue.
And Jamil bhai, I second that, because this is very interesting. I don't know whether Rafique bhai is there or not, because the rhythm also is very interesting.
Yeah.
And we need the next move will be to get an echo at least, and then we can talk about further management because of the palpitation.
Can I say something?
Yes, sir, Rafique sir.
Okay. So it looks
Rafique bhai,
like, yes, Hafiz. So it looks like junctional rhythm, but look at the first QRS complex in lead 1.
Yes, sir, I was telling about that.
There is a P wave, right?
Yes, sir, and with a delta wave. Sir.
But you cannot see the same P wave in lead 2.
Yes.
So this lead 2 rhythm is misleading. I think it is all along sinus rhythm, and there is a supraventricular premature beat. The part that is not, but of course in lead 1, then you can see a delta wave. So with the presence of the delta wave makes the whole thing, any other diagnosis, very difficult or irrelevant with the pre-excitation. So it's a kind of funny ECG because the subsequent QRS complexes, but again, same, if you look at the V6, the first ECG, there is a P wave, but you cannot see the same P wave in the lead 2.
Yes.
So there is something wrong with this lead 2, and if we gain it up, probably we'll be able to see the P wave. So
But,
I wondered if it is all.
So there is a negative P wave in lead 3 also, and on the first bit.
Exactly.
Yes.
Exactly. But the third bit doesn't have any P wave.
Yes.
So that probably is a junctional bit. But then again, if you look at the last, the first bit in the V6, there is a P wave which is not visible. So I think there are some of these are probably sinus, supraventricular beat, whether it's sinus or not, that's a different story. But the third bit appears to be junctional because there is no P wave anywhere. Sometimes you can see, I mean, it's a junctional escape beat, or sometimes you can have actually escape beat from the accessory pathway itself. But if it were accessory pathway premature beat, it will be much wider than it is. So how is the patient doing? What did you do?
So nothing needed for the patient. So it's actually Jamil sir and Rafique sir has rightly pointed it out. So these QRS complexes having no P waves in front are the junctional escapes. So these are coming from the junction, and that's why they have no P waves. But these delta waves, these QRS are having P waves in front of them. So they are coming from above. So these patients has no doubt has an accessory pathway, but these are a result of fasciculoventricular accessory pathway. And that's why, and these beats are originating from the junction, and that's why they have no. And here the patient has a hypertrophy cardiomyopathy, and we know that the hypertrophy cardiomyopathy is associated. So if a patient is having fasciculoventricular accessory pathway, they are rarely very symptomatic. So you don't have to do anything for them, and it's a benign thing. So the patient is doing well, and it was an incidental finding.
That's the most important thing, perhaps, that you do not overdo things in this type of patient. I would be asking the question that whether she had any syncope or any.
No, nothing was there. She had one leaf.
Exactly. And we should not do too much with this type of ECG. Rafique sir, my question is, what happens in future in this type of, when the patient have this type of ECG and as well as a structural problem, hypertrophic cardiomyopathy?
I mean, we'll have to, do we know if the patient has hypertrophic cardiomyopathy or we don't?
Sudhir, she has hypertrophic cardiomyopathy, is it?
Yes,
we don't know that.
She has hypertrophic cardiomyopathy.
By echo proven. You
Yes.
know, hypertrophic cardiomyopathy patients have higher incidence of WPW. The
Yes.
other part is that you have to be careful about patients who have WPW have a higher incidence of AFib also. And this is the important thing to remember. If this patient develops AFib, they're at high risk of thromboembolic complication. I mean, it will all depend, but whether to ablate the accessory pathway or not will be dependent based on the symptom of the patient and documentation of tachycardia.
Sir, I think Dr. Sudhir,
Yes, sir.
we really appreciate you have shown some very beautiful and very intriguing ECG. We really congratulate you and
Thank you.
show our appreciation from our ECG study group, particularly from Atahar Bhai and myself. And now I would like to ask Dr. Rafique sir to start his presentation.
Okay. I'm stopping this share now. Okay, sir.
Rafique sir,
Thank
আপনি
you.
কি এখন দেখাবেন একটু?
Yes, just 1 second. Trying to struggle with this sharing business. Let me see. All right, got it. So this lecture, I think Hafiz will like it because I have been using imagination in explaining this ECG. So I'll start with one ECG, this one, and I have questions so we can give the poll.
Sir, for 30 seconds.
30 seconds, please.
Okay, sir.
I'd like as many people as possible to answer. We always appreciate it because it gives us, we feel good when you answer the questions and it gives us feedback that how we are doing. Okay, so a good number of answers. 19 people answered, but so who wants to take it? Jamil?
To me, it looks probably in the bottom strip in V1, there is some T waves can be imaginated, superimposed on the T waves, which are very thick but short. And this may be atrioventricular reentrant tachycardia, sir. AVRT.
Okay. Yeah. So a few people answered ventricular tachycardia, and I get the point why you did that, because it looks a little bit wide, but the duration is about 110 milliseconds. So even then, I can take a diagnosis of ventricular tachycardia if I can apply all the criteria that we discussed in the past. If you look at lead V1 and V2, especially V2, the initial R wave is very narrow. That goes against VT with left bundle type. From the beginning of the QRS to the deepest point of S wave in the chest lead is not more than 100 milliseconds. That goes against VT. We don't have concordance, we don't have AV dissociation. So ventricular tachycardia is actually out of the question. The rest of them are all valid diagnoses. Question would be, is it atrial flutter? If it is atrial flutter, if it is a 1-to-1 flutter, then 174 heart rate is a little slow flutter. If it is 2-to-1 flutter, that makes it 348. That's a little, no, not 348, 170.
Around 350.
350. That makes a little too fast a flutter. So, of course, I always try to use my imagination. I looked at, when I saw this ECG, I said, something is not right. If you look at lead 3, the T wave looks distorted, but it is not something that we normally see. And I thought this is a P wave. And that's why Hafiz, I think Hafiz is laughing and has a big smile on his face because he thinks, that's Rafique by making up these stories. Hafiz, are you with me? No, Hafiz. Okay. So let's look at it. I enlarged it. This lead 3. I'm talking about this part. And I thought this is the P wave. And RP. You remember that we talk about SVT, long RP, short RP. That's how we measure. From the beginning of the QRS complex to the P wave. That's RP. That's 220 milliseconds. From the P to R is 120 milliseconds. So this, if I'm correct that this is the P wave, then it is a long RP. I'm actually making a statement if I am correct, because I started with an imagination that this is the P wave. So this is a long RP tachycardia. Now, if it is long RP tachycardia, what are the possible diagnoses? These are the possible diagnoses. Top one is AVNRT. The P wave is within the QRS complex. You cannot see it. P wave immediately after the QRS complex is the short RP tachycardia. That's AVNRT or AVRT. Or here, again, short RP tachycardia. But this is what we have, that's long RP. And long RP can be atrial tachycardia, sinus tachycardia, or it can be atypical avinodal reentrant tachycardia. So these are the 3 possibilities that we are left with. Now, so if I go back again, if it were AVNRT, atypical, usually you will see a negative P wave, but this is not, this looks like kind of biphasic P wave. So I thought this is probably atrial tachycardia. So what will be the final proof? How can I make sure what it is? Can anybody in the audience, or shall I just go? So what we did is a simple thing to do is to give adenosine and look at what happened with adenosine. There is heart block and there is continuation of the P wave. And that takes out diagnosis of avinode reentry or atrioventricular reentry. It is extremely unlikely that an avinode reentry will continue despite AV block. It is impossible for atrioventricular reentry to continue. So that proves the diagnosis of atrial tachycardia. And this is the patient when it converts to sinus rhythm. You can see the P wave and biphasic P wave million, and there is a PVC. So just to recap, please, we need to get into our head the concept of relationship of PR and RP. Short RP tachycardia, long RP tachycardia. This is a short RP. That means RP wave is shorter than PR. Most likely AVRT. If it is long RP tachycardia, it is either atrial tachycardia, sinus tachycardia, or atypical aveneural reentry tachycardia. So these are the possibilities in these cases.
Sir, sir, Wadud bhai?
Yeah.
The question is, we often get confused when it is atrial tachycardia, when it is atrial flutter. If you
Yes.
have typical flutter wave, that's very easy.
Yes.
But here, the rate actually helps to determine that it could be atrial tachycardia. But what are the points that we can use?
Yeah. So I'll take Atahar's question, comment in a second. So the question that it is a question of semantics a lot of the times, because conceptually, this P wave is very discrete P wave, and it is most likely an automatic focus. If it were a macro reentry circuit, you will see as you get circuit gets bigger and bigger, you will get more like sawtooth appearance of atrial flutter. So, and there is of course a gray zone that clinically we think it is atrial tachycardia, but when we do electrophysiologist atrial flutter, so it is a question of rate that we use. The rate was 174. If it became 220, I would not call it atrial tachycardia. It can be atrial tachycardia, but it will be very fast atrial. That's why the gray zone comes in. But if I can see, normally what we do, if I can see isoelectric line between the P waves, we call them atrial tachycardia. If we don't see that, then it is the diagnosis of atrial flutter, like the sawtooth appearance. Atahar?
Sir, actually, sir, is there any role of the last bit of tachy, sir, after that is the last terminated bit tachy for the differentiation, that is the atrial tachy?
Yes. Yes. So what Atahar is asked, the question that Atahar asked, that unfortunately here the tachycardia did not terminate, so we cannot discuss that. What he's talking about, let's say the tachycardia stops here. And if there is a P wave here or no P wave, that can decide what type of tachycardia you have, but that will be at the time of termination. Because if there is a retrograde P wave and the tachycardia stops, it is unlikely to be atrial tachycardia. That means because if it was atrial tachycardia, it would have conducted. I'm not talking about in this case. This is where we gave adenosine. But if the tachycardia terminated with a P wave, then it was unlikely to be atrial tachycardia. It is either atrioventricular reentry or aveneural reentry. And there is a block in the antegrade pathway. Thank you, Atahar.
Thank you, sir.
So look at this. So I support my imagination. Look at, I had superimposed when the patient is in sinus rhythm, look at the T wave, and this is during the tachycardia. You can see the distortion of the, and it is not isolated distortion. There is some wobbly, but it is clearly there in all the complexes. And that's why we look at. But interestingly, that when the patient is in front of you, you may not have the normal rhythm ECG. So that's where you have to come up with this decision and what to do. Okay, this one.
Input time is up.
Top competition. is
Yes. This is good. Atahar, you want to comment on this?
Can we take a comment from some of our junior panelists we have got, sir, in the screen?
Yes, please,
You are
please.
Dr. Poppy Bala.
Dr. Shailanavi is also here.
Poppy Bala,
Yes, sir.
Shailanavi, Poppy Bala.
Yes, sir.
Unmute.
Hello, sir.
Unmute and open your that is video on, please.
Sir, video cannot be on, sir, but I can comment on the ECG, sir. I'll
Sure,
try my
please do.
So rate is around
166.
166, and it seems to be regular, sir. Regular, and there's P wave followed by QRS, and the P is upright, can be seen the V1, but all are positives, and PR is variable. So most probably, sir, this is an atrial tachycardia.
Sure. So whoever answered atrial fibrillation, I give credit to them also, because what they looked at is the irregularity. And if you look at in the bottom rhythm stream, it almost looks like AFib because there is a little bit of irregularity, it's a fast rate, and you cannot tell it. So there is a credit to it. But the question is there any P wave? Now, if I look at lead V1, you can see these discrete P waves. So that takes AFib out. So that will be rational. So atrial flutter with 2-to-1 conduction, if it were atrial flutter, where my P wave is, there is a second P, there should be another one in the middle. There is none in the middle. So it is not atrial flutter with 2-to-1 conduction. Now I have left with avinodal reentient tachycardia with atrial tachycardia. There is a possibility, but if you look at lead 2, you can see after the T wave, there is a positive notch. And that is the P wave that we are seeing in lead V1. If it were avinodal reentry, it will be negative P wave. So is my story correct? Let's look at it. What I have done is, again, I have expanded it, this lead V1. You can see the P to P interval is regular, 360. Why there is irregularity? Because there is, as Poppy mentioned, that there is some irregularity in the conduction. And this PR is longer, that created the irregularity. And again, the R to P is 250 millisecond and P to R is 140 millisecond. So this is again a long RP tachycardia, which leaves us with diagnosis of sinus tachycardia, atrial tachycardia, or atypical avinode reentient tachycardia. Because the P wave is not negative in 2-3 AVF, avinode reentry is out, sinus or atrial tachycardia. But P wave in V1 is not biphasic, it's monophasic looks like, and this most likely is an atrial tachycardia. So let's look at this patient. Again, when patient goes to sinus, you can see the P wave here is biphasic, and this is the premature beat. So clearly that was an atrial tachycardia. So we'll do this one. And this will be, there'll be 3 ECGs and this will be last cases.
We are requesting our participant to vote. 13 votes so far, sir. More vote.
Yes, please.
Yes, sir. More vote, please.
Okay. So good, 21 people answered, and we have, so any junior faculty to comment on this?
Jillu
have-
Rahman, Shaila Nabi, or anyone?
Sir, sir, can I make a comment?
Please.
Sir, to me, it seems like to be sinus rhythm followed by atrial tachycardia.
Okay.
3.
Why do you think it's not AFib? Why?
Okay.
No, I want to ask a question. Why did 50% of participants answered atrial fibrillation? What was the rationale?
Sir, their rationale was perhaps when they looked at the lead V1, lead 2, there is
Yeah.
some RR irregularity and no
Yes.
clean cut P wave.
Exactly.
But
exactly.
if they have
No
looked the lead V1, then the scenario would have changed.
There is
Yeah.
also electrical alternance in the B1, the QRS complex.
Yes.
That goes in favor of atrial fibrillation.
Yes. So I think Tushar is right that we have P wave here, P wave, and then when the tachycardia starts, it starts with a P wave.
Yes, sir.
So that favors atrial tachy. Even in lead 2, you can see something. You see, this is the T wave, but suddenly T wave becomes not positive, which is similar to this P wave. So this is atrial tachycardia. Of course, as we always have the temptation to call it AFib because of the irregularity. And that is one of the things that can happen. A lot of atrial tachycardia can be diagnosed as atrial fibrillation, depending on the lead. It cannot be AV node reentry. Why? Because if it were AV node reentry, the first beat should have different kind of P wave if it were a reentrant beat. And the first beat causing the SVT will have a longer PR interval. That's how normally that's how it starts. So this is sinus rhythm. And then, of course, the same patient, when we did, we continue to follow, you can see when the rate is a little slower, you can see the 2 P waves. So this is a patient on rhythm skip on a different time. It can see P wave. And the same patient, when he converts to sinus, I have these few choices. If we could give a poll, give us a few seconds, and then let's give the poll, and this will be the last EC.
Sir, before that, previous is one more question, sir.
Yeah. Go ahead. Atahar?
The previous is after this is, sir.
This one?
Right, sir.
Yeah.
We will please stop the poll.
Sir, there is a term MET, that is the multifocal atrial tachycardia. Does this ECG fit with this term, sir? Because of the variation of the P wave morphologies?
Well, the multifocal atrial tachycardia
Rate is too high, I believe. Yeah.
Right. But the other thing is that we have to prove that there are 2 or more morphology, more than 3 or more. But it's not. If you look at lead V1, lead 2, all looks positive if it is really there. And lead V1, we can't clearly see it. I think we need more 12-lead ECG to prove that. And in a single lead, we have to find multiple morphology. But this is something that we need to keep in consideration. Of course.
Yes, sir. If we follow the lead V1, as
Yes.
sir said, Atahar sir said, if the initial part, the presumptive P wave is a bit wider, whereas in the later part, the P wave gets smaller in amplitude and duration. Is not the same type of P that started the 80 and the later half of the lesion strip, a slight change in the morphology of the P wave. I think Atahar sir is mentioning that because of that math. Is it possible,
Yes.
sir?
Well, give me 1 second. Just 1 second. I have to answer this.
Okay.
Should be.
And another, sir, another thing is that the age of the patient is written here as
Just 5 more minutes.
35 years male, which probably is a bit clue because
Yes.
most of the MAT patients are COPD or elderly patients, which again goes in against the MAT.
Yes. Yeah. I'm coming to the comment about the P wave. The first P wave is outside the T wave, and that's where you can clearly see it. But then, of course, when it gets superimposed on the T wave, it can distort its shape. So it is very difficult to make a judgment based on that. So I think it's probably a single focus tachycardia, but we have to keep that in consideration. Let's look at this ECG.
That you have given enough clue in the answers.
Well,
but I do hope the people get used to this, that they have to describe in detail. They start practicing this. Sinus rhythm, what's the change in the P wave? Is there any ectopics or any STT wave changes? All these.
okay. So we have again, I think, who wants to comment on this?
Azizul Haq.
Yeah, I think definitely when you look at that, it's fairly regular except for one beat. The definitely there's a PAC there. So if you look at the just with the answer, the premature beat is there at the very last one, okay? And definitely look at the P wave complexes, definitely biphasic there. So left atrial enlargement is there. And so so sinus rhythm, left atrial enlargement, supraventricular premature beat. And there's some, you can comment on ST changes there, more like T wave abnormality more than the ST changes. So that complex comes along the number 4 looks like, because only premature beat is there, number 4.
Yes, and the last one is, that's what I was saying, enough clues in there. But my question is, this is a 35-year-old male. Why does he have that type of left atrial enlargement, but no ventricular enlargement?
Yeah, well, unfortunately, I don't have an echo, Wadud. I wish I had an echo on this patient report. So from exam standpoint, what Wadud was mentioning, this, if I did not know anything, I knew very basic ECG, and I could identify a premature beat, I could answer this question correctly. The last beat is a premature beat, and only question that has premature beat is a supraventricular premature beat.
Yeah, just looking at that, you can answer. Yeah.
Yes. So when you are taking exam, even if you didn't, this will be an exam taking skill. That okay. Second question is it a normal ECG? Let's forget everything. But if we know T wave, the T wave is inverted biphasic in 2, 3, and inverted in lead 3 and AVM. So this is not a normal ECG. So by exclusion, this number 1 is totally out. So the question is that, is it biatrial enlargement or left atrial enlargement? So that is a question. And if you look at the morphology of the P wave, it's classic, what we call P mitral, right, Karul? And so this is how it looks like. If you look at P wave, this is a normal P wave. The solid line is the right atrium. The dotted line is the left atrium. So when there is left atrial enlargement, the terminal part increases. When there is P pulmonal, the right atrial part enlarges. But the problem that happens, sometimes you can have P pulmonal simulated by left atrial enlargement. And that's when you have to look at lead V1. If you look at lead V1, if it is right atrial enlargement, the initial positive deflection will be bigger than the second deflection. So let's look at this ECG. So I have enlarged this P wave. You see, it is more than 2.5 millivolt, but it is the terminal part that is higher. So there is no right atrial enlargement. So the initial part did not fulfill the criteria. If we look at lead V1, it is the terminal part, the D part, the initial part is not high. So it is, even though the amplitude, if we just go by amplitude, one have a temptation to call it a right atrial enlargement, but it is not. It is because of the left atrial enlargement. And of course, there is STT wave changes and low voltage. I wish I had an echo on this patient. I did not. So that's why we're going to leave it. Wadud, any comment?
Sir, it's the most important thing I always say, because when you see a ECG, this should stimulate question regarding the clinical management. This is a 35-year-old male. I would be asking the ethnicity of the patient. Is he an Asian? Has he come from Vietnam? If that is so, I would ask for whether the patient have mitral stenosis or any other evidence of that.
Yes, it's interesting because 30 years in the United States, I just saw one patient with mitral stenosis because I had the opening snap. And it is very uncommon, but it is there. And of course, the ethnicity of the patient is also important. So there are rheumatic mitral valve disease in this country, very infrequent rheumatic mitral valve disease. Thank you.
Thank you, sir. We really enjoyed it.
The beauty of Rafique sir's presentation is that sir collects the ECG, almost the similar type of ECG, which clearly differentiates the confusion. If we follow the three ECGs, he showed us that atrial tachycardia. Why this is atrial tachycardia? Why not it is atrial fibrillation? The so similar looking ECGs, but why we call atrial tachycardia? Sir has clearly mentioned that in his lecture and his ECGs, and it's sir's tremendous ability to collect, store, and to reproduce those things.
Thank you.
I really wish that our youngsters would be doing that themselves. They'll be collecting the ECG, but please make a photocopy of it or a scan, because most of them will fade away if you don't do it quickly. And later on, always please keep a note on it about the clinical scenario. That will give you pleasure whenever you go through those collections. And if you wish, you can share those enjoyment with us in this forum. We'll be there for you. Atahar bhai, would you please make a comment and the ending?
Thank you, Professor Abdul Chowdhury, and thanks everybody for their participation and our honorable faculties. And first of all, I want to congratulate Dr. Sudhir, our resident student, for your beautiful presentation and showing some interesting and I think exceptional ECGs. Congratulations to Dr. Sudhir. Now we can believe that our report, particularly from our panelists, especially Professor Abdul Wadud Chowdhury, Chowdhury Hafizul Ahsan, Azizul Haq, and finally, it is the Rafique sir has got some positive report. What was our target? That is to stimulate our student to give them actually some interest about the ECG. Possibly we have got something, and Sudhir is an example of that. That is our attempt is not in vain. Actually, we are getting some result, and this was the objective of the study group, and we are achieving this. And finally, actually, like Dr. Tushar, it is our Rafique sir actually who is giving his effort, maintaining the same momentum of this program, showing some exceptional ECGs, unbelievable collection, an exceptional presentation. This is a teaching for us. I personally like to present like Rafique sir, but this is, I think this is totally impossible. I have not, sir, I collected some ECG, but I cannot prepare, sir. I don't know how you collected. This is an exceptional, sir. You are a great teacher. I am learning and learning and learning all through the program, sir. Really, this is the excellent. You are the main, actually, you are the main stream, sir, who is maintaining the same effort of this program. Our participants are enjoying. I got many phones from our students that it is you, sir, actually, who is maintaining the same strength of this program. And actually, our Chowdhury Hafiz has actually added some positive role. So, I want to congratulate you, sir. Without you, this program is totally impossible. Exceptional presentation, sir. Thank you very much. And again, Sudhir, congratulations. And we hope to see some of your exceptional ECGs again. Dr. Sudhir, you can share your
sir. এবং আমি স্যার অনেস্টলি বলি স্যার আমি এরিথমিয়া যতটুকু শিখেছি রফিক স্যারের কাছ থেকে শিখেছি স্যার থ্যাংক ইউ সো মাচ
and finally one Dr. Rafique sir suggestion, that is try to collect your own patients ECG, Sudhir.
স্যার আমরা তো স্টুডেন্ট এবং আমাদের তো ওয়াইড রেঞ্জ অফ পেশেন্টস নাই, যেগুলো পাই সেগুলো রেখে দেই, কিন্তু ওইটাও কিন্তু ওয়ান অফ মাই ফ্রেন্ডস হু ইজ ইন চন্ডীগড় হ্যাজ প্রোভাইডেড মি PGIMER.
Yeah, that's great.
Chowdhury, Abdul Chowdhury.
Okay, let's close the program today. Thank you.
Thank you, everybody. We enjoyed your companionship all through the year in this COVID era. And actually, this is making us sane. Otherwise, I think I myself would have gone insane doing nothing, something very good in this situation. At least give you some purpose in life. You see, the study group is really giving us that. And as Rafique sir was saying, we are teachers. We are here to teach and share and learn ourselves in the way to doing that. And that's what we are doing. I hope in future, you will be doing that. And me, Atahar sir, Rafique sir will be clapping our hands and giving ourselves kudos that we have done what we wished for. Thank you, everybody. We'll be seeing you again and again next week, the week after, and hopefully for a long time.
Thank you.
Sir.
Thank you, sir.
Assalamu alaikum, sir.
Thank you, Rivu.
Atar Bhai, we have to thank Beximco and Rivu
Right,
and
exactly.
our team. They are doing so much for us. We are really grateful to you all.
Thank you, sir. Thank you.
Sarah, thank you very much for your
Thank
exceptional.
you.
Thank you, sir.
Assalamu alaikum. Good night.
Walaikum assalam, Abdul Chowdhury. MG Azam, congratulations.
জি স্যার বলেন স্যার।
না MG Azam, তুমি কোনো কথা বললে না কেন?
না স্যার আমি শুনতে ভালো লাগে স্যার।
না, আজম কিন্তু ইসিটি এতে খুব মনোযোগী শ্রোতা, একদম প্রথম থেকে আমি দেখি। থ্যাংক ইউ আজম।
না শুনতে ভালো লাগে স্যার।
But we want to see you, Azam.
না আসি স্যার, আসি আপনাদের সাথে আসি স্যার।
Thank you very much. Now, we always actually enjoy your company. You are a good academician.
না না স্যার, থ্যাংক ইউ স্যার।
Anisul Awal, thank you very much for joining.
আনিসকে অনেকদিন মিস করতেছি। আনিস, we want some মানে some interesting cases from you.
ঠিক আছে, দিব স্যার ইনশাআল্লাহ।
খোদা হাফেজ সবাইকে। আমি আসলে সারাদিন এই পরীক্ষা নিয়ে একেবারে এক্সস্টেড।
থ্যাংক ইউ। আমাদের নেক্সট সানডে কিন্তু আমাদের শরদিন্দু আছে, শরদিন্দু ভেরি একাডেমিক ইসিজি লাভার।
উনি কনফার্ম করেছেন স্যার মেইলে। আচ্ছা স্যার, তাহলে কনক্লুড করে দিচ্ছি স্যার। আসসালামু আলাইকুম।
এক মিনিট।